continuing our series of educational videos on new protocols and updates in the Kentucky State EMS protocol for 2023. Again, as always, if you have not adopted these protocols, don't consider this to be a medical order or authorization to use them. You have to follow the protocols that your medical director has approved and that the board of EMS has ratified. But that said, if you are on the state protocols, hopefully this gives you a little bit of idea about it, and otherwise you can call it education. So let's talk the Safe Patient Conveyance Protocol, or guideline, or informational sheet. The reason that we put this in here was to say, what are the different ways that you might have an order to move somebody from place to place in the back of an ambulance? What are the forms we could do that? Because I feel like it's important to say, yes, some of this stuff is all right, some of it is not all right. Certainly, this stuff at the top basically says you have to have the patient restrained with the ambulance, either the ambulance manufacturer's restraint system, i.e. seat belts, or with the ambulance cot manufacturer's restraint system. And you have to have all the buttons and all the buckles fastened essentially all the time, realistically. If it's got 5 points, then it's 5 points. If it's 3 seat belts, then it's 3 seat belts. But you have to have all that done per the manufacturer device that is in there. That's the way to keep patients safe and protect yourself and protect them. The different ways to transport somebody. We've got the classic supine trauma position, i.e. the patient is flat on their back on the stretcher. And again, we usually use this because we're like, oh, we got to protect the spine. We got to do that kind of stuff. And usually supine is actually one of the worst ways that you can transport somebody. It's not the worst way by far, but it's one of the worst ways that you could transport somebody. Nobody walks flat on their back. Nobody sleeps flat on their back for that matter. And we take these injured patients and we stick them flat on their back. And God forbid we could put them on a backboard. Hopefully nobody's still doing that. And then transporting them on that backboard, but I know it's out there. So supine is one way that you could do it. Supine with head of bed elevated to 30 degrees is probably a pretty reasonable idea, and we're getting a little bit better. It improves ventilation, it decreases work of breathing, it's more comfortable for most patients to have their head of bed elevated. And if you take the 80-year-old gentleman who is out ATV riding, but also has COPD and CHF and wears 3 liters of oxygen all the time and hasn't laid flat on his back in 10 years, and then you lay this person flat on his back after he fell off his ATV, there's a good chance you're going to run into an airway and breathing problem in short order. So it is okay, even if you don't know if they have a spine injury, even if they say my back hurts, it is actually okay if you have to maintain their breathing and oxygenation to elevate their head of the bed by about 30 degrees or so. Maybe don't go a ton more than that because somebody will get mad at you. But if airway breathing is compromised by laying flat, then go ahead and raise their head of bed. It is okay to transport many patients upright or semi-upright with the head of bed elevated at least 45 degrees. And if they don't have any signs or symptoms of spine trauma, it's perfectly fine to do that. Even if they were in a car accident, they don't have to go flat on their back. If they don't have pain, tenderness, or neurological deficit, and they're not drunk, distracted, or confused, i.e. you can do the spine assessment stuff, then it is okay to raise their head of bed to 45 degrees and take them to the hospital that way for their hurt ankle or hurt leg. That's okay in most cases and more comfortable for the patient. What you may not have seen before that I toss in here just as, let's say this is an option, is the lateral trauma position. So this has come a little bit more of interest in Europe, and I don't want to do things just because Europeans are doing it, but this is a reasonable idea, and it's backed up by some data as much as any of the transport things are backed up by. What you do is, we always called this the recovery position when we were doing, just general first aid. You have them in a decubitus position on their side, arms, sort of stretched out in front of them. If you have concern for a cervical spine injury, then you can place a C-collar on them for all the good that will do. But you're going to support their head in a neutral position with pillows or with towels or with rolled up sheets. You're not just going to let their head, dangle around. The reason that you're doing this is to allow the patient to clear their airway. So if somebody was, say, shot in the mouth or shot in the neck and they are coughing up blood or vomiting blood, don't put them on their back. If you're going to do anything, you can put them on their side so at least, again, the blood or the vomit or whatever it is that's coming out doesn't go straight down their trachea afterwards. This is a good way to help maintain the patient's airway. And yes, somebody may fuss at you a little bit, but you can pull out this and say, haha, Lubber says I can do it. If if that is the case, if somebody fusses at you. And we'll explain how hypoxia and loss of airway are much more deleterious for a trauma patient, especially someone who has neurotrauma, than does the small amount of movement that would be involved with getting them into the lateral trauma position. You still put restraints on these folks. You still put the belts across them and use the manufacturer recommended restraint system for this. You just turn them on their side essentially to maintain their airway. Folks still occasionally transport on a rigid backboard. A backboard is fine to get somebody off the ground with, or to pull out of a bathroom, or to get out of a ditch, or to pull out of the bottom of a canyon. It gives you handles, it secures the patient, it does all that kind of stuff. Once the patient gets to an ambulance cot, though, the benefit of the backboard has gone away, and now you're only getting the harm. So there is no reason to transport a patient almost ever on a rigid backboard. If it's 6 minutes down the road to the trauma center, doesn't matter. Take them off the backboard. It only takes a second to do it. How do I know that? Because we take people off the backboard all the time. Either don't put them on it or take them off it before you transport these folks. And then that brings us to the prone position, which we are never going to transport a patient in unless it's part of a recognized therapeutic intervention, i.e. some people who have advanced ARDS may oxygenate better if they are transported in a prone position. This takes a hell of a lot of work to do, and most of the time anybody who's using this set of protocols is probably not doing prone patient transports. The only other times when this is acceptable is they have a fence post stuck through them, and the only way you can transport them is on their stomach, which it's still a pretty dangerous idea. If that's what you're stuck with, that's what you're stuck with. But patients should not be transported in a prone position, generally speaking, by EMS, with very few exceptions. And that's it. So it is a relatively quick one. If you have any questions, let us know. Otherwise, be safe out there, and we'll see you on the next one.